Hello students, welcome to this YouTube session of high-yield question of anesthesia and emergency medicine, and I am Dr. Swati Singh, your anesthesia and emergency medicine faculty on Allen Next. Hope you are doing your preparation with full enthusiasm. I am here to boost up your preparation with some high-yield question from the expected topic which I presume to be asked in exam. Okay, so without wasting any time, welcome all of you. Let us start with some high-yield question. Now, the first question, I have picked up this question from ventilation, right? Since from last, let's say 2-3 exam, I am seeing a lot of questions being asked from the ventilation, right? But this question which I have picked up is a question on non-invasive ventilation. Most of the question till now has been asked on invasive ventilation, but I have picked up from non-invasive ventilation because I expect that they can ask on the settings of non-invasive ventilation also now, okay? Because a lot of question already has been asked on the settings of invasive ventilation. So what is the question? The question is, a 48-year-old patient was admitted in ICU with acute exacerbation of COPD. He was put on BiPAP. Patient was put on BiPAP with following setting: IPAP 12, EPAP 7 and respiratory rate 15. After half an hour, an ABG was done and his pH was 7.15, PaO2 was 79 and PCO2 was 88 mm of Hg. Now, what change in the BiPAP setting is required? Now, this patient, as you can see by his ABG, that patient is in respiratory acidosis. His CO2 has increased in the blood and this is respiratory acidosis. So, patient is in ventilation failure. Patient ventilation failure. Patient is going into hypercapnic respiratory failure. So, we have to improve the ventilation. His oxygenation is adequate. PaO2 is adequate. So, his oxygenation is adequate. But what is getting affected is ventilation. So, PaCO2 is not getting cleared. So, what change in the setting I will do which will improve the ventilation of the patient and remove the carbon dioxide from the blood? Before seeing the options and choosing the right answer, let us see this image. If you see this image, you can see that there's a ventilator, the ventilator tubing and the patient interface. You can see this is the patient interface. This is not a endotracheal tube, but a tight-fitting mask. When the patient interface is a tight-fitting mask, we call it non-invasive ventilation, right? We call it non-invasive ventilation. And when we are using endotracheal tube, we call it invasive ventilation. Okay? So, non-invasive ventilation definitely has some clear-cut, benefit over invasive ventilation. See, it is compared to invasive, non-invasive, there's a less incidence of ventilator-associated pneumonia, right? Less infection seen in the patient. So, we always try, if possible, to manage a patient by non-invasive before going into invasive ventilation. Kind of, it can be a bridge therapy which can improve the patient and prevent the patient requiring the invasive ventilation. Those number of times, it cannot supplement the requirement of invasive ventilation. It has some clear-cut indication and some absolute prerequisite which we have to fulfill before putting a patient on non-invasive ventilation, right? So, in this, what I will talk about the indication, the contraindication of non-invasive and modes of non-invasive. There are 3 important modes. One mode has been asked in the question. The mode was BiPAP. So, what is this BiPAP and what change in the setting in BiPAP is required for improving oxygenation and ventilation? We'll discuss. Then CPAP, continuous positive airway pressure, and PSV. Now, these are the 3 modes of non-invasive ventilation. BiPAP stands for bi-level positive airway pressure. Bi-level positive airway pressure. Okay. CPAP stands for continuous positive airway pressure. Okay. Continuous positive airway pressure. And PSV stands for pressure support ventilation. Pressure support ventilation. So, these are the 3 important modes which we have to discuss. So, before I discuss these modes and their setting, let us see the indication why we put a patient on non-invasive ventilation. Well, the indication is same why we put a patient on invasive ventilation. the respiratory failure. So if patient is in respiratory failure, two things will happen. Patient will become hypoxemic, his PaO2 will decrease. So in respiratory failure, two things happen: hypoxemia and hypercapnia. Either of it or both. So in hypoxemia, in ABG, PaO2 will be less, and in hypercapnia, PaCO2 will be more, right? So for preventing hypoxemia, we have to improve the oxygenation of the patient. And for preventing hypercapnia, we have to improve the ventilation of the patient. We have to improve the minute ventilation, then only carbon dioxide will be cleared. Okay, so this is the reason, indication of putting a patient on ventilation, invasive or non-invasive. There are some clear-cut, let's say, conditions in which non-invasive have proven to be beneficial. Now, first indication in which it has been clinically proved that non-invasive is very beneficial and should be tried before putting a patient on invasive ventilation is COPD. Various studies have shown in COPD, non-invasive have improved the patient and the requirement of invasive has been prevented. What happens in COPD? Mostly it is hypercapnic respiratory failure, right? Hypercapnic respiratory failure. So what is the mode required in COPD? In a second, I will tell you. The second indication, pulmonary edema, acute pulmonary edema, right? In acute pulmonary edema, well, why is ventilation required? To decrease the afterload and decrease the load of the heart, unload the heart, right? And for this, again, non-invasive ventilation has proven to have clear-cut benefit. And what we required here is to improve the oxygenation of the patient by unloading the heart, improve the oxygenation of the patient in pulmonary edema. So what is the mode required? In a minute, I will tell you. Then the third indication, out of ICU indication, obstructive sleep apnea. Patient of obstructive sleep apnea in whom hypoxemia happens because of respiratory obstruction when they sleep have shown clear-cut benefit from non-invasive ventilation. Obstructive sleep apnea. Apart from this, it has shown some benefit in pneumonia, in the early stage of pneumonia. It has shown some benefit in ARDS, though these two, well, clear-cut benefit has not been shown. And definitely, non-invasive has shown to have a very good way of weaning the patient from invasive ventilation. So we are not able to remove the ventilator from the patient. We can take the tube out and as a bridge therapy use non-invasive ventilation when the patient is ready for weaning. So we can use it even for weaning. So these are the indications. Now, what are the prerequisites and what are the conditions in which we cannot put non-invasive? See, it is the patient interface is tight-fitting mask. So if patient is unconscious, weak, patient will aspirate. So comatose patient, absolute contraindication. Now, if patient doesn't have a respiratory effort, patient is in apnea or an impending respiratory arrest or cardiac arrest, we cannot put this mode, right? Then if patient is not an inability to clear the secretion, again the risk of aspiration. So we cannot put the patient on non-invasive ventilation. You're getting my point? Now, if patient is uncooperative, not cooperating with because we need the cooperation of patient for proper ventilation in non-invasive. Again, it is difficult, though it is not an absolute contraindication. And if the mask which we are using is not giving a tight fit, then again the purpose of ventilation will be not solved with non-invasive. Okay, so contraindication is comatose patient, inability, let's say impending respiratory arrest, patient is going into respiratory arrest. Now we cannot manage with non-invasive, we have to put on invasive ventilation. Then inability to clear the secretion, then uncooperative patient, though we sometimes try in uncooperative patient, they improve and then they start cooperating, and then patient, let's say in whom the mask is not fit, seal of the mask is not achieved. So patient ill-fitting mask, with ill-fitting mask. Number of times we change the mask, we try to bring the right fit mask, but number of times then also the fitting is not good. Then those patient, the ventilation cannot be achieved if we don't have a tight fitting mask. So again, it is kind of a contraindication. Okay, so I talked about these three modes: BiPAP, CPAP and PSV. And let us first talk about CPAP. Let us start with CPAP and then I will go on BiPAP. These are the two modes which I will discuss. BiPAP has been asked in this question. But before going into BiPAP, let me talk about what is CPAP. As I told you, CPAP is continuous positive airway pressure. It is simplest mode. It is the simplest mode, right, of NIV. And in this mode, only a positive airway pressure is selected. Right, a constant pressure. We select a CPAP pressure of 10 mm of Hg, and this 10 mm of Hg is a constant pressure throughout the respiratory cycle of the patient. Right, so a constant pressure is set via the ventilator that is provided throughout the respiratory cycle, Okay, so what exactly it is doing? It is a positive pressure throughout the respiratory cycle on which inspiration and expiration is happening. It is increasing the FRC, the functional residual capacity, right? Patient has to initiate his own breath. Patient has to, his respiratory muscle has to be active and initiate his own breath. Ventilator will not help in initiating the breath. What ventilator is doing in this mode is increasing FRC, functional residual capacity, and this increase in FRC augments oxygenation. So this will augment oxygenation by alveolar recruitment. So it will increase FRC, it will decrease shunting, it will augment oxygenation. So this mode is useful when we have to improve the oxygenation of the patient, not when we have to improve the ventilation of the patient. Got my point? So in pulmonary edema patient, right, where we have to improve the oxygenation, the CPAP mode would be the best mode, right? In, let's say, obstructive sleep apnea patient, where we have to just maintain the oxygenation, the CPAP mode would be a good mode, right? But in hypercapnic respiratory failure, where we have to improve the ventilation also, we need another mode, and that another mode is our BiPAP mode. So what are the setting of BiPAP? So if you see this image, this is the image of the different setting which we require to do in BiPAP. IPAP, EPAP, a basal respiratory rate, FiO2, right? Just concentrate on these four. Now IPAP. IPAP is inspiratory positive airway pressure. EPAP is expiratory positive airway pressure. So EPAP is basically analogous to CPAP, right? CPAP was continuous positive airway pressure throughout the respiratory cycle, inspiration and expiration. EPAP is a constant pressure on which inspiration and expiration will happen. That expiratory positive airway pressure would remain throughout the respiratory cycle. That much pressure would remain in the alveoli throughout. So what EPAP will do, the same thing what CPAP was doing. It will increase functional residual capacity, improve the oxygenation. Okay. Now what happens that the ventilator cycles between this low pressure, that is expiratory positive airway pressure, and IPAP, a high pressure. When the pressure cycles from EPAP to IPAP, this augments the tidal volume. This will help in increasing the tidal volume, and it will also help in initiating the breath, right? A basal rate has been set in the BiPAP. So machine or patient can initiate a breath, and what will happen? The pressure, the positive pressure would increase by the machine will apply a higher positive pressure over EPAP, and that would be IPAP. And this higher positive airway pressure will augment the tidal volume of the patient. So remember that the difference between IPAP and EPAP, when it is increased, when this difference is increased, the augmentation of the tidal volume is increased. This will This is increase the difference. This augments the tidal volume. This augments the tidal volume. So if I have to improve the ventilation, I have to keep this difference higher. I have to increase the difference. The tidal volume will be augmented and ventilation would be improved. If I have to improve only oxygenation, I have to increase EPAP only. And if I have to improve the ventilation, I have to increase the difference between IPAP and EPAP, right? So what we do? How do we start? We start with a minimum setting. Just as you can see in this, EPAP 4 was applied and IPAP 12. Let's say I can start with EPAP 4 and IPAP 8. And I see adequate tidal volume is not being achieved. PaCO2 is still higher. I can increase the IPAP. I can make it from 8, 10, from 10, 12. And I will increase the difference. And this will augment the tidal volume. And this will clear the carbon dioxide from the blood. It will improve the ventilation. So in this patient, coming back on our question, patient was in ventilation failure. PaCO2 was high. I have to augment the tidal volume. So what would be the change in the ventilation? IPAP was 12, EPAP was 7. First option, I increase IPAP to 15 mm of Hg. So from 12, we are increasing to 15. Definitely, the difference between IPAP and EPAP will increase. So with the first option, the difference between IPAP and EPAP will increase. This will augment tidal volume. So it seems the right answer, but let us see the other options also. Increase EPAP to 10. Well, if I increase EPAP to 10, the difference would decrease. It will improve oxygenation, but it will not improve ventilation. So this is incorrect. No change in the setting required. Definitely change is required. Respiratory rate is to be increased. See, this is the basal respiratory rate, right? We should not increase the respiratory rate. It's a basal respiratory rate is kept in BiPAP. To augment tidal volume, what we do is increase the difference between IPAP and EPAP. That would do the job better, not increasing the respiratory rate in this case. So answer is A. Increase IPAP to 15 mm of Hg. So this was my first question. Unexpected question, right? Okay. The second question I have picked up, again an expected question on let's say management of cardiac arrest. A 37 weeks pregnant patient was on magnesium infusion as management of preeclampsia. Well, number of times you will get a patient, OBS patient on magnesium infusion for preeclamptic patient. When resident was on the round, she found the patient unresponsive. So patient was unresponsive. So once you find someone unresponsive, what do? We call for help and then we check for her pulse and breathing. So she must have called for help. On examination of her pulse was feeble. So pulse is present, right? Pulse is present. But there was no visible chest movement. Respiration is absent. So because of the magnesium infusion, which can cause respiratory arrest, the patient has gone into respiratory arrest, right? She is not into cardiac arrest. She is in respiratory arrest. So what we will do for the management options? Rescue breath at the rate of 10 breath per minute. Chest compression to be started. Stop magnesium infusion. Give pain stimulus to the patient. Well, what we immediately do in the respiratory failure? We start rescue breath at the rate of 10 breath per minute in adult. Well, chest compression would have been started if pulse was also not present, but pulse was there, so we will not start with chest compression. Stop magnesium infusion, that is not a priority. We will stop, but first we have to start ventilation. So option should be the rescue breath. And giving pain stimulus, well, patient already is written is unresponsive. So a stimulus must have been given. She is unresponsive. So giving further stimulus will not do the job. So answer is A. If you see this chart, this is very important chart for exam. I mean, I would say this chart, well, always an expected question from this chart. This is a basic life support management, BLS chart of AHA, American Heart Association. So what does this chart says? That when you find someone unresponsive, you do scene safety, then call for help, and then you check pulse and breathing. Okay, look for pulse and breathing. Now, normal pulse and breathing, which was asked in your exam, pulse and breathing both present. So what you will do, you will make the patient in the let's say left lateral position, that is recovery position. So you will turn the patient in recovery position to prevent any aspiration, but you will not give breath, you will not start chest compression because both pulse and breathing is present. Pulse is present but breathing is not there. So breathing is absent, breathing absent, pulse is present. Patient is in respiratory arrest. So if patient is in respiratory arrest, what do? We give rescue breath. We have to give rescue breath and check for the pulse every 2 minutes. And if no pulse and no breathing, neither pulse is there nor breathing is there, then we start with CPCR, that is chest compression. So always remember this sequence. Got my point? So this is the basic life support management chart. So different patient scenarios can be given, but only 3 things can be for the answer. If both pulse and breathing is there, recovery position. If pulse is there, breathing is absent, rescue breath. If both pulse and breathing are absent, chest compression, CPR has to be started. Remember this, right everyone? So this is the basic life support. Okay. Now coming on the next question, see, I have picked same from cardiac arrest. A 38-week pregnant female in cardiac arrest was being resuscitated. What is the time to do perimortem cesarean delivery for better outcome? So this is a special condition of cardiac arrest. A special condition is a pregnant female. So a pregnant female, when she goes into cardiac arrest, there are some special things which we need to do in addition to the basic life support. The same basic life support we will do in any cardiac arrest, but some special intervention we have to do. So if you see this chart, this is the chart of managing cardiac arrest in pregnancy. So whenever we see a patient in cardiac arrest, we always, I have already done scene safety, I have called for help, there is no pulse, there is no breathing. So cardiac arrest is established. So what do? We start with high quality CPR. So we start with CPR. High quality CPR. We defibrillate if it is indicated. If it is we attach a defibrillator, and if it is, let's say, shockable rhythm, we give shock like any other cardiac arrest management, same thing, right? And other ACLS intervention like giving adrenaline and giving amiodarone, etc. So everything same. But what is special which we do in the pregnant lady? There are some maternal intervention, there are some fetal intervention, because we have 2 patients, a mother and the fetus. Okay. So you are managing at a time cardiac arrest in 2 patients, right? And remember, a good outcome in both is dependent upon a successful maternal resuscitation. So your priority is mother, not the fetus, right? Your primary priority is mother. So what is the maternal intervention? Well, maternal intervention in a pregnant patient in cardiac arrest, remember, first, provide the airway management. See, pregnant lady, they are high risk for aspiration. So we try to secure the airway as soon as possible, right? Then 100% oxygen should be given. We have to administer 100% oxygen, and we have to avoid excessive ventilation. 10 breaths per minute, not more than that. Why? They are high risk for aspiration. Then place IV line, the IV cannula above diaphragm, right? IV cannula has to be placed above diaphragm. Why? Because of the aortocaval compression. In pregnant lady, right, the gravid uterus after 20 weeks compress the great vessel aorta and vena cava. So when you are doing resuscitation of the pregnant woman, 20-week plus, we always perform a continuous left lateral uterine displacement. This is the obstetric intervention. So we perform a left lateral uterine displacement to prevent pressure on the great vessel, right? So this we have to do. We don't have to do any fetal monitoring during the CPR. Why? Because again, I am telling you, priority is mother, and fetal monitoring can interfere with maternal resuscitation, right everyone? Okay. So IV line above diaphragm, that is in upper limb. Then intubate as soon as possible or use a supraglottic airway device, right? Perform a left lateral displacement continuously throughout the management of cardiac arrest, that is during CPR, okay? And you do the CPR for, let's say, 5 minutes. In 5 minutes, return of spontaneous circulation has not happened. we plan for perimortem cesarean delivery, right? If ROSC, we have to perform perimortem cesarean delivery if ROSC is not in 5 minutes, right? So immediate perimortem cesarean delivery has to be done. If we will separate the fetus from the mother, the chance of successful resuscitation would improve. So in this, the answer is 5 minutes of cardiac arrest. When a pregnant lady goes into cardiac arrest, we start preparing for perimortem cesarean delivery. And within 5 minutes, we try to perform the perimortem cesarean delivery, right? Okay, this is a special circumstances of cardiac arrest. Since a lot of question is being asked on this topic, the general question has been asked. Now they can ask for the special circumstances. So I'm going for the special circumstances in this topic, right? One more special circumstances which can be asked in exam is respiratory arrest in patient due to opioid overdose. Apart from all the intervention according to the BLS algorithm, what extra we can do in this patient? We have to give naloxone as soon as possible. Then cardiac arrest due to local anesthetic systemic toxicity. Apart from regular intervention, the CPR, what extra we will do? We will give 20% intralipid emulsion. So I talked about some special circumstances. Special circumstances. Opioid overdose. Extra, what is extra? I'm only writing extra apart from normal BLS and ACLS. Naloxone. Naloxone as soon as possible. Then local anesthetic systemic toxicity resulting in cardiac arrest. Apart from normal, 20% intralipid emulsion. Right? In pregnant lady, apart from normal, few extra things. IV line above diaphragm, intubate as soon as possible, and then do a left lateral uterine displacement continuously during resuscitation and perimortem cesarean delivery within 5 minutes of arrest if ROSC has been not achieved. Okay. Now cardiac arrest due to unknown poisoning. Some unknown poisoning, right? What extra in unknown poisoning? Unknown poisoning, the extra is 20% intralipid emulsion, right? We give the infusion of 20% intralipid emulsion. So this is cardiac arrest in special circumstances, okay? A lot of questions I have discussed, okay? Okay. Now coming on the next question. Which of the following oxygen delivery device delivers FiO2 within 0.2 to 0.6 independent of the patient's breathing? Well, if you see this term, independent of the patient breathing, what oxygen delivering device you have to choose? Just don't pay attention on FiO2 also. If you see independent of the patient breathing, you have to choose the device which provides fixed FiO2. Fixed FiO2 independent of the patient breathing. If the device is FiO2 is dependent on patient breathing, then it is variable FiO2 delivering device. Only fixed FiO2 delivering device will provide FiO2 independent of patient breathing, right? So fixed FiO2 high flow device will come into high flow device we have to choose. So if you see the option, it's a very simple question. Simple face mask. This is a variable FiO2 delivering device, not fixed FiO2. This is dependent on patient breathing pattern. Venturi mask, fixed FiO2. Fixed FiO2 delivering device. So it seems the answer, but let us see the other option. Non-breathing mask, again variable FiO2 delivering device, right? Nasal cannula, normal one, variable FiO2 delivering device. So what would be the answer in this question? Very simple question. Answer would be Venturi mask. So fixed FiO2 high flow devices. Two important devices you have to remember. Venturi mask and HFNC, high flow nasal cannula. Here simple nasal cannula is in the option, which is a low flow device. High flow nasal cannula is a high flow device, a special device attached with a let's say oxygen air mixer, right? So this high flow nasal cannula provides a high flow and fixed FiO2. Normal nasal cannula provides low flow and variable FiO2. So answer is Venturi mask. Got my point? Independent of patient's breathing pattern. So if we say this is a Venturi mask, this is a Venturi mask, right? Normally This is the oxygen tubing. Normally the oxygen tubing opens in the mask, then it is not Venturi mask, then it is a simple face mask. But when the oxygen tubing is attached to this Venturi barrel, attached to the mask, Venturi barrel, then it becomes Venturi mask. Got my point, everyone? Okay, this is based on Venturi principle, right? Venturi principle, by which room air is entrained when we give a high flow of oxygen through this tubing, through this barrel. If I attach the tubing to the barrel and give a high flow of oxygen, room air is entrained. So it becomes high flow. It becomes a high flow device. And FiO2 is fixed. See, this is color coded. The Venturi barrel is color coded. And on every barrel, it is written what is the flow we need to keep and what FiO2 it will deliver. So always with each barrel, a fixed FiO2 is delivered. So this is a fixed FiO2 delivering device, the Venturi mask. Okay. Here I have shown few devices. Nasal cannula, low flow device. The conventional nasal cannula, low flow device, variable FiO2. Venturi mask, a high flow device. See, this is the Venturi barrel. This is a simple face mask. Tubing opens in the body of the mask. And this is a face mask with a reservoir bag, that is NRBM, non-rebreathing mask. So non-rebreathing mask, simple face mask and nasal cannula, they come under variable devices, variable FiO2 delivering device. And Venturi mask is fixed FiO2 delivering device, right? Nasal cannula, it flow what we have to keep, right? We start with 2 to 4 liters, we keep it 2 to 4 liter per minute. What FiO2 it gives? 21 to 45%. Okay. Venturi mask mixes with room air. I told you room air entrainment happens. And what FiO2 it gives? 40-60%. I mean, rather I would say from 0.2 to 0.6. Why Venturi mask? Maximum FiO2 0.6. Simple face mask 40 to 60% FiO2. 6 to 10 liter we have to keep the flow. And non-rebreathing mask 10 to 15 liter, and it can give a very high FiO2 if patient has a stable breathing pattern. What if patient does not have a stable breathing pattern? It will not give the desired FiO2. So it is a variable FiO2 device, depends upon the breathing pattern of patient, NRBM. But it can give a very high FiO2 if patient has a stable breathing pattern, a normal respiratory rate, right? So this is about our devices, okay? Now the next question, the last question for the day. An emergency patient with obstructed airway was brought to emergency department. Resident was unable to do mask ventilation or intubation in the patient. What is the immediate management required in this patient? So difficult, this is a question on difficult airway. This is a question on difficult airway. And resident was unable to do mask ventilation and intubation. So it's an emergency situation. This is a situation, cannot intubate, cannot ventilate, right? I am not able to intubate, I am not able to ventilate. So immediately what we will do? Options are tracheostomy, cricothyroidotomy, jet ventilation, retrograde intubation. Now all are the management when I am unable to do the intubation. But in this cannot intubate, cannot ventilate situation, immediate situation, emergency situation, what would be the answer? The answer has to be cricothyroidotomy. Because tracheostomy is an elective procedure. It will take some time. It is not an emergency procedure. Cricothyroidotomy immediately between, let's say, if you see this is your thyroid cartilage, this is your cricoid cartilage. In between is cricothyroid membrane. We take a thick bone needle and go inside. We go inside and what we do, we connect it to the syringe and we connect it to the ventilator, high jet ventilator, and so we give a very fast ventilation and we try to maintain the oxygenation of the patient. Or we create a nick here and try to put a tube and through that we do a ventilation. Now, cricothyroidotomy is a temporary procedure. It is not a permanent procedure, right? For tracheostomy, right, we have to make a hole in the trachea. This is the cricothyroid membrane. For cricothyroidotomy, we make a hole and go in the airway by this path. And for tracheostomy, we have to make a hole between second and third tracheal ring or first or second tracheal ring. It is made in trachea. This is elective, right? And this is Cricothyroidotomy is emergency. It can be done immediately. This requires some time. Okay. So tracheostomy, remember, it's an elective procedure. It cannot be done in emergency. And this is procedure of choice in cannot intubate, cannot ventilate situation. Jet ventilation, until and unless you put an airway, you cannot do a jet ventilation. After doing cricothyroidotomy, you do jet ventilation, but you have to do cricothyroidotomy first. Retrograde intubation. Now, this is the retrograde intubation. It is also done in when we are unable to put the endotracheal tube from the oral cavity or the nasal cavity. We put the tube retrogradely from the trachea through a guide wire and we take it out from the oral cavity. Retrograde we call it. It is done also in difficult airway management, but not in cannot ventilate situation because it will take time. It is again an elective. So it is management of difficult airway. It comes in management of difficult airway, right? But cannot be done in cannot intubate and cannot ventilate situation, right? For cannot intubate, cannot ventilate situation, immediately you have to start the ventilation of the patient by some means, right? And this will take some time, retrograde intubation. Okay, so answer has to be cricothyroidotomy. Again, an expected question. Now, before ending this question and the discussion, I just want to tell you the difference between tracheostomy and cricothyroidotomy. Now, tracheostomy, I told you, is elective. Cricothyroidotomy is emergency. Now, tracheostomy is done within second and third tracheal ring. Cricothyroidotomy in cricothyroid membrane. So, this is your thyroid, this is your cricoid, and then your tracheal rings. Okay, this is the first tracheal ring, this is the second tracheal ring. So, tracheostomy will be done here and cricothyroidotomy will be done here. So, if an image-based question is asked, a needle is high up in the neck, it is crico. If needle is low in the neck, it is tracheostomy. Got it? Then tracheostomy is a long-term thing. When we put a tracheostomy tube, we can keep it for a long time. And cricothyroidotomy is a temporary procedure. Then tracheostomy, we can do open tracheostomy, that is called surgical tracheostomy, or percutaneous. Crico, we can do needle cricothyroidotomy, or through a scalpel, we can do a tube cricothyroidotomy. Okay, so this is the difference between tracheostomy and cricothyroidotomy. Okay, now before ending again this question, some important tracheostomy tubes. Well, the first tube in the image, this is a cuffed tube, cuffed tracheostomy tube, right? If patient is on mechanical ventilation, this is the tracheostomy tube of choice. So, for mechanical ventilation, this is what is required to obtain a closed circuit for positive pressure ventilation. So, always cuffed tracheostomy tube we will use, right? Cuffless tracheostomy tube, right, is a tube which we cannot use for mechanical ventilation. When the patient is ready to be removed, decannulation, for decannulation we can use cuffless tube. So, this cannot be used for mechanical ventilation. Patient will aspirate and a seal will be not created for positive pressure ventilation. Then we have fenestrated tracheostomy tube, that is tracheostomy tube with opening in the wall. This is when we are, let's say, encouraging the patient to vocalize. So, this is for vocalization. This fenestrated tube is used when we are asking the patient to vocalize along, let's say, in between ventilation. For air to pass, we need a gap. We can also deflate the cuffed tracheostomy tube and we can encourage the vocalization, but it's better to use a fenestrated cuff tube. That is used when we are encouraging vocalization, right? Okay, one more tracheostomy tube which I want to show you is, this is a metallic tracheostomy tube. Now, this is not used when a patient is on mechanical ventilation, metallic tracheostomy tube. This is only used when you have put a patient on tracheostomy for a long time because patient is not able to maintain the airway. Some obstruction or some reason patient is unable to maintain his airway, we put a metallic tube for long term, creating unobstructed passage for the air to go. Patient can breathe on his own, is not on ventilator. Just we have to maintain the patency of the airway. Then we put this metallic tracheostomy tube. This can be removed, washed, and again put in the patient. You're getting my point? So this is the different type of tracheostomy tube. So these were the few questions which I wanted to discuss with you and which I expect which can be asked in exam. Now, thank you so much for your patient listening and best of luck for your exam.